Gradishar, Professor of Medicine at Northwestern University, where I am also Chief of Hematology Oncology. So my view of using molecular tests to help in decision-making for adjuvant therapy is that we have gone a long way since, say, a decade or even 2 decades ago, when we relied entirely on clinical features of the tumor to make a decision regarding what's the optimal adjuvant therapy, be it chemotherapy or endocrine therapy or some combination of both. And we now have a number of different tools, two of which have been referenced. One is the Oncotype recurrence score, and the other is the MammaPrint, which is a 70 gene assay. And both of these tools in many ways provide similar information. They both define a very favorable group of patients who can probably avoid chemotherapy. And they also identify a group of patients where chemotherapy probably should still be considered because anti-hormone therapy alone is insufficient. The evolution of this has been over the last decade, certainly with the Oncotype test or the recurrence score. We started out looking at a very large experience referred to as TAILOR-X that demonstrated that you could define in node-negative patients those patients who could avoid chemotherapy based on the scores that come back. And more recently, again, these experiences and these trials took years and thousands of patients to accrue. But more recently, the RxPonder trial, which in many ways could be viewed as the TAILOR-X trial for node-positive patients, demonstrated that you could define patients who could avoid chemotherapy, particularly among the postmenopausal patients, based on the score from that test. In younger patients, premenopausal patients, it became less clear. And I think that one of the observations that have been made both with MammaPrint and recurrence score as it relates to young patients is the question of whether it's a chemotherapy effect or whether it's something that the chemotherapy does that results in ovarian suppression. In other words, again, in an ER positive population, might the chemotherapy have the effect of ablating or suppressing the ovaries? So in some patients, although chemotherapy may be considered based on the results of these tests, there are select patients where instead of chemotherapy, we may choose in young patients with either node negative or node positive patients to utilize maximal or optimal endocrine therapy that includes ovarian suppression ablation rather than chemotherapy. So how I would summarize it is there are both tests that are available. I wouldn't say one is better than another. Certainly in the node negative population, we clearly have been using in our own institution the Oncotype recurrence score more commonly. We think it's not only prognostic, but predictive of chemotherapy benefit. In the node positive population, we now have the RxPonder trial that validates our ability to define patients with up to 3 nodes who might be able to avoid chemotherapy, particularly if they're postmenopausal. And the MammaPrint or 70 gene assay has also been able to define a very favorable group that can avoid it. So I wouldn't suggest that one is necessarily, you must use it, it's the best, but these are tools that can selectively be utilized to enhance a clinician's ability to optimize their treatment recommendations.